Okay, starting with our first question, that is, which of the following is not included in ABCD2 score? So just try to understand this. This ABCD2 score is a score that is used to predict the future chances of stroke in a patient with TIA. So understand this, why we use a score. So I told you in the class also, this could be like an expected question and this question came in exam. So this score is used to predict stroke in a patient with TIA. TIA means transient ischemic attack. So in this you can see A for age, B for BP. So age is a feature, yes. BP is a feature, yes. We give 1 point for BP also. Diabetes and duration of symptoms. So remember, current stroke, current clinical feature, it is a feature of stroke. But remember, previous stroke is not a feature. Previous stroke is not a feature of ABCD2 score. Clear guys? Am I clear? आगे चलें. फर्स्ट क्वेश्चन, पहला क्वेश्चन सही हुआ नहीं हुआ? Okay, there are many doubts for other subject as well. So just see, am I clear? Try to, I'm just reading your doubts as well. So just try to ask me your doubts in the comment box. Let's move to the next question. Shoaib Ansari, Doc, Abhi, Shivani, आगे चले. Okay, then this ECG was given, or some students are saying ECG was not given, but again they're asking like all are seen in WPW syndrome except. So again we have discussed this in WPW and long Devine syndrome. These are two syndromes which are associated with short PR. So QRS can be prolonged. That is what we see broad QRS, but PR is not prolonged, it is short. Delta wave is classical feature, right? So PR shortening is seen, PR prolongation is not seen. So just let us see what we have discussed in our LN next tab. We have discussed WPW and non-Devine syndrome. So you can see a bundle of Kent, we have bundle of James Mayhem. You can see broad QRS. Here you will see normal QRS. Here you will see delta waves are present, delta waves are absent. Then treatment of choice for this condition will, both case condition will be, because these are because of fibrant pathway, so it will be like a radio frequency ablation. Am I clear? आगे चलें. So देखो पेपर टफ आया था, I can understand. First paper was a bit difficult, but medicine was not difficult this time. There were a lot of questions from the straight forward topics. तो घबराने वाली बात नहीं है. पेपर 2 में मेडिसिन में से 40 में से आउट ऑफ 40 यू हैव मेड मोर देन 25 करेक्ट, ट्रस्ट मी. तो 25 तो यहीं सही हो गए, पास तो अपन वैसे ही हो गए. समझ आया? ओके. Patient had road traffic accident. Presentation is having bradycardia and hypertension. So what we call this Cushing reflex. GCS is 6. So there is low GCS. SpO2 is 82. SpO2 भी कम है, GCS भी कम है. What should be the next management? Now we don't know it's stroke or not. So thrombolyze करने का तो पता ही नहीं है. IV fluid we will give, but IV fluid there's hypertension already. Urgent CT head, but this is a condition like this patient need an urgent intubation because SpO2 is low. Am I clear? So it's an indication of urgent intubation of this patient. Okay, आगे चलें. Okay, coming to fourth one. So patient present with edema. So edema, ascites and raised JVP. So these are all feature of right heart failure. So there is increased liver enzymes. On evaluation, portal hypertension was present. Means there is damage to right side of heart. Damage to right side of heart. And also there is portal hypertension means there is congestion in the liver. So what we call this? We call this chronic passive congestion of liver, or we call this cardiac cirrhosis or nutmeg liver. It can occur due to cardiac failure. So it's the case of cardiac failure. So it is a liver cirrhosis in a patient, that is because of right heart failure. Am I clear? Okay, बताओ समझ आया नहीं आया? So see, this is a nutmeg liver. We have discussed same thing. We call this chronic passive congestion of liver, that is right heart failure leading to cirrhosis. Okay, moving to next one. What can be given to celiac disease patients? So this is like a question again, you know, like we have celiac brew, we can give barley, rye, oat and wheat. Barley, rye, oat and wheat. So understand now, see the option, what we can give. So suji or semolina, suji and dalia, these are two product of wheat. तो ये तो आपको नहीं देने, this you can't give to patient. Oat you cannot give because oat is in bro, barley, rye, oat, wheat. So oat भी नहीं देना. Rice पुलाव, बिरयानी, आप चावल दे सकते हो. So remember, R is not rice. I mentioned this clearly. So R is not rice. So this was the question came in exam. And rice you can easily give. तो राइस पुलाव बिरयानी खिला सकते हो. तो ये तो सबका सही हुआ है ना, क्यों घबरा रहे हो, कहाँ गए सबके सब? Is this correct or not? Okay, moving to next one, layer absent in esophagus. So like I told you, like this is a layer like serosa. This is considered absent because only in esophageal stomach junction, we call this gastroesophageal junction or squamocolumnar, only in that area it's present. So it is negligible. The serosa is negligible or absent in esophagus. So layers, that is serosa. Again, it's an anatomy overlap MCQ, but again came from our app, so that's why I thought to discuss this question. Clear? Okay, moving to next one, Duke's criteria. So like some students are saying, they were asking question like how many are component in and minor category. So you can see like there is fever, vascular phenomena, immunological phenomena, some predisposing event or blood culture positive, which is not satisfying, blood culture not satisfying the above criteria. So that is like these are 5 features. So I could not get the exact question, but remember in Duke's criteria there are total 5 minor criteria. So I think this was the question. You can give your input in the comment box. There are total 5 minor feature in Duke's criteria. Moving to next straightforward question, non-caseating granuloma. So it is like a first line of sarcoidosis, which you can see non-caseating granuloma. So again, question came straight away from the notes. So non-caseating granuloma you will see in a patient with sarcoidosis. On the other hand, caseating you will see in a patient with tuberculosis. Am I clear? Okay, आगे चलें. Drug of choice for facial nerve palsy. So understand this, for facial nerve palsy, suppose if you are getting a patient on time if you give steroid, then there is like a good improvement in symptoms. So remember, otherwise like we do just physiotherapy, we can give to patient. Otherwise remember there is not much improvements in later on. So try to start steroid as soon as possible. So drug of choice will be steroid. So steroid only one option. What we have prednisolone. Increase aldosterone and decrease renin is seen in. So I could not get other option, but what I can show you is like as we have discussed in our again in our app, that is increase aldosterone and decrease renin. That is a classical feature we see in a patient with Cohen syndrome or primary hyperaldosteronism. So that is seen there in a patient with Cohen syndrome. Clear? You can also type in the comment box what are other options. So like in our app in the YouTube also we can make a full video with all 4 options. Okay, आगे चलें. HIV patient is diagnosed with TB. What is investigation of choice? So remember, I told you like in most of the cases like HIV patient they have sputum smear as negative. In that case, how we make a diagnosis? We make a diagnosis by doing CB-NAT. So investigation of choice for a patient who is diagnosed with HIV and TB, what we do? We do CB-NAT. CB-NAT is cartridge-based nucleic acid amplification test. We also call this as gene expert. Gene expert. Moving to next one, the 70-year-old man present with a low backache. 70-year-old man with low backache, KFT is deranged, LFT is normal, gamma globulins are disproportionately increased, X-ray spine showing lytic lesion. So what is the defect, origin of defect? So understand this. This is a question where they're asking you like the diagnosis is clear. It's a case of multiple myeloma, and multiple myeloma it's a tumor of plasma cell. So basically they're asking like what is the site of defect. So remember, multiple myeloma it's a tumor of plasma cells. Moving to next one, patient present with ataxia, confusion, ophthalmoplegia. So you can see a classical triad, GOA, that is global confusion, ophthalmoplegia and ataxia, that's seen in a patient of Wernicke's encephalopathy. So it's a case of Wernicke's encephalopathy, and Wernicke's encephalopathy you can see that is due to thiamine deficiency. So again, this is like a straightforward question which came in exam. So paper is not that difficult, but you are thinking, don't worry, tum pass ho, trust me, paper अच्छा गया है. सही तो हो रहा है ना? Okay, patient presented with feature of dermatitis, diarrhea and delayed wound healing. So like remember the most important metal which I can say for wound healing, that is your zinc, and most important enzyme will be matrix metalloprotease. So diarrhea in children, we also give ORS with zinc. So remember, this is the case of zinc deficiency. So zinc is that element which is important, and there is a condition which is occurring due to zinc deficiency, that's called acrodermatitis enteropathica. So actually it's a case of acrodermatitis enteropathica. Acrodermatitis enteropathica, that is due to zinc deficiency. It's an autosomal recessive condition. So this is the answer for this question. Moving to next one. Pregnant girl with increased bleeding post dental extraction, PT is normal, and there is thigh bruising. So just try to understand this. Whenever we talk about like a primary platelet disorder, then remember this will affect your bleeding time. But in disorder of clotting factor, you will see PT, APT will be affected. So a factor 9, if you see factor 9 and factor 8, these are ruled out. Why? Because the question is mentioning girl. Am I clear? So just try to understand this. Hemophilia A and B. Factor 8 deficiency is hemophilia A. Factor 9 deficiency is hemophilia B. These are ruled out. Why these are ruled out? Because these are seen in boys. These two conditions are X-linked recessive and X-linked recessive condition. These are in boys. Now coming to vitamin K deficiency. So vitamin K dependent clotting factor, what we have clotting factor 2, 7, 9, 10. So here you will see there will be PT and APTT both will increase. PT and APTT both will increase. So PT will increase, APTT will increase. On von Willebrand disease, you will see it's a defect like von Willebrand factor, the transporting factor for factor 8. So here you will see there is a decreased von Willebrand factor. So what will happen? You will notice when this is deficient, there is an indirect deficiency of factor 8. So factor 8 means your I can say intrinsic pathway will be compromised. So APTT will increase, but PT will be normal. PT will be normal. That's why the answer for this question will be von Willebrand disease. So you can clearly see in this question the hint is PT is normal. PT is normal. So this is the hint they're asking about von Willebrand disease. Am I clear? Okay, आगे चलते हैं. 40-year-old patient with difficulty in eating due to dry mouth. So first hint in the MCQ you are getting is as a dry mouth. She also has dry eyes, keratoconjunctivitis सिक्का. So इससे easy कुछ question नहीं हो सकता. Then the cervical lymph node. Cervical lymph node means maybe the patient is developing some sort of like a marginal zone lymphoma. So it could be because of lymphoma, and marginal zone lymphoma is very common in a patient with Sjogren syndrome. So all these are features which are suggestive of Sjogren syndrome. Is it clear? So sarcoidosis is diagnosed as occlusion in Wagner's granulomatosis. There was also, I know like there was a question on Wagner's granulomatosis as well. So that also we'll discuss later on. Don't worry. आगे चलें. In Wagner's, it's mainly a vasculitis. So you will not see like these dry features. MCTD is the condition where you see like features of 2 or more autoimmune conditions. Coming to next, a patient present with hypotension, muffled heart sound. Hypotension, muffled heart sound, and raised GVP. So you can see like this is what we call this Bake's triad. So this is like a topic which is like FMG exam favorite, and it's coming from past, I can say now 3 years. Past 3 years FMG favorite topic. So you can notice here like this is a classical feature like Bake's triad, decreased VP, hypotension, increased JVP, muffled heart sound. So I also told you mnemonic, that mnemonic was PATEX. PATEX means pericarditis will have a prominent Y descent, tamponade will have a prominent X descent. Prominent X descent. So this is so diagnosis will become cardiac tamponade, and in cardiac tamponade what you will see a prominent X descent. Prominent X descent. So prominent X descent means that is not given in the option. Prominent Y you will see in pericarditis. So what you will see when one X or Y, any one is prominent, means other will be decreased. So there will be like absent Y descent. So answer for this question will be absent Y because there is prominent X. Is it clear? Prominent Y you will see in constructive pericarditis, And large C wave, you can see, and multiple defects, absent A wave, you will see in a patient with atrial fibrillation. So these are ruled out options. Okay, then this is like an interesting question which came in exam. A 60-year-old bedridden patient developed breathlessness. So again, look at the age of the patient, 60-year-old, breathlessness. CTPA means like it's like computerized tomography pulmonary angiography. So that is actually the investigation of choice. CTPA is investigation of choice for pulmonary embolism. So CTPA was done, right? Now CTPA is done. So it's a case of, so diagnosis I can make with this, that is a case of pulmonary embolism. So which investigation should be used to help finding etiology of presentation? So what else we can do? So remember, one thing is what we can do, we can go for like a color Doppler of vein, because most of the embolus, this will come or this will migrate from lower limb. So that color Doppler is not given in the option. Echocardiography, no. Coaglogram, I will not give you any significant finding. MRI is not needed because we have already confirmed the diagnosis with CTPA. So what can help is D-dimer we can do, that can help in confirming a diagnosis. But remember, already diagnosis confirmed, just D-dimer will help you to make a diagnosis. So actually क्या करते हैं, पहले D-dimer करते हैं, फिर CTPA करते हैं. लेकिन क्वेश्चन आपसे उल्टा पूछ लिया. So they are already telling you like CTPA is done. So what else we can do? We can do D-dimer test. Am I clear, guys? D-dimer test. Coming to next one, radiological investigation of choice for pheochromocytoma. So understand this. We have discussed in the class, like pheochromocytoma, first thing that we test is urinary metanephrin, then we'll go for plasma metanephrin. Like if you want to localize the tumor, for localizing to see the tumor, what we do, we go for MRI abdomen. So MRI abdomen. But if tumor is small, in that case, remember, if it is small means less than 1.5 centimeter, that is not seen in MRI. In that case, we can do MIBG scan or we can use a DOTA-TED scan. Is it clear? So even for like extradenal pheochromocytoma, what we call this as paraganglioma. In case of paraganglioma, we straight away go for DOTA-TED scan. So this thing also we have discussed. So remember, here what we are doing, it is just they're asking about investigation of choice. So first thing what we'll do, we will do MRI. Am I clear? MRIs. Suppose in this question, if I ask you like radiological investigation for a pheochromocytoma that is smaller, then answer will become MIBG scan. Okay, then this was a question of rule of half. So rule of half we have discussed. Like again, circle was given, so you can see half will be diagnosed. Out of this half, so half will be treated, right? And you can see half will be adequately treated. So I think there was a question based on circle, like how much percentage. So half means how much percent will be adequately, that will be less than half, around 12.5%. So that was a question, that is rule of half is basically for hypertension. So they are asking like a mark adequately treated. So this is the circle, this is the area which I am marking here. This is the area. So let me mark this area. So this is the area which is adequately treated. Clear? That is rule of halves. Okay, coming to next, a person bought 2 bottles of liquor from a liquor shop and later presented with drowsiness, ataxia and blurry vision. Name the antidote. So again, it's a case of alcohol toxicity. So what will be the antidote? So understand, antidote, like some students are saying like fomepizole was not given. So it is not given, then in the option there should be ethyl alcohol. So flumazenil is the antidote for benzodiazepine toxicity. That I think this question also came in exam. Naloxone we give for opioid toxicity. Diazepam is again a benzodiazepine, so that will not use. So answer will be fomepizole. If it is not given, then answer will be ethyl alcohol. So I think friend, in these only one of them is given the option. I think many students are saying ethyl alcohol was given, so this is the answer. Okay, am I clear, Rohan? Okay, coming to next, benzodiazepine antidote. So that you already know now, flumazenil. So we have discussed this, flumazenil. So remember, I told you like drug of choice for alcohol addiction, disulfiram, for withdrawal, benzodiazepine, and for alcohol toxicity, what we give fomepizole. So again, from our straight away from our notes, the question came in exam. So what is the mechanism of action of bedaquiline? This was a question that came in exam. I think I have placed the wrong slide here. So this is like it's inhibiting ATP mycolic acid synthase. This was the question which came in exam. This will inhibit ATP mycolic acid synthase. Coming to next one, calcitonin is a tumor marker. This was the question straight away. So you can see calcitonin is a tumor marker for medullary thyroid carcinoma. Calcitonin is a tumor marker for MTC, that is medullary thyroid carcinoma. I think there was also a question on most common. So remember, most common thyroid cancer will be papillary cancer of thyroid. Papillary cancer of thyroid. A patient presents with symptom of confusion, ataxia, ophthalmoplegia. What is vitamin deficiency? So again, it's the case of Goa. So Goa means that is, you will see thiamine. Thiamine means it is vitamin B1. So this is straight away like Wernicke's encephalopathy case. So this was asked in exam, and I think most of you have marked this correct. Okay, coming to this was like a dose-based question, interesting question which came in exam. So loading dose of Altiplase in 80 kg person. So just look at the screen what I have discussed. Altiplase we give 0.9 mg per kg. So maximum what we give 100 mg. So initially what we give 10% as bolus. Now see, 80 kg is the weight of person. So how much you will give as bolus? So remember, we will give 8 mg. 10% will be 8 mg. So this was a question like loading dose, that is the loading dose. As bolus what we give, that is the loading dose. So loading dose will be 8 mg. Rest we will give like as an infusion over 1 hour. So remember, Altiplase dose they have asked in mg. So in 80 kg what we give 10% we give as bolus, and rest 90% we give via infusion. Am I clear? Okay, coming to next, a 33-year-old woman evaluated with excessive daytime sleepiness from past 1 year, BMI is more. So this was a straight away question. This same question came in INICET in this attempt. Same as repeated in your exam. So BMI is more. You can see BP is more. PO2 is you can see 70. PCO2 is 53. So bicarbonate is 33. So it's like a patient having respiratory acidosis. So it is not Cushing syndrome because even it's not OSA or CSA. It's a case of obesity hypoventilation syndrome because patient is having respiratory acidosis. This thing also we have discussed. Obesity hypoventilation syndrome. All of the following will have hypokalemia except. So again, I could not take the screenshot of because I could not have that time. But remember, all these questions came from the notes. All of the following will have hypokalemia except. So remember, most of the RTA they will have hypokalemia. Type 1, yes. Type 2, yes. Type 4 is RTA is renal tubular acidosis. So remember, RTA type 4 is hyperkalemic type. Is it clear? And this ureterosegmentoscopy, this will lead to nagma, or I can say, so again here you will see hypokalemia. So only in RTA4, RTA4 is called hyperkalemic type. Okay, child is brought with a 2 to 3 weeks history of not feeding well and irritability, history of TB in sister. LP was performed, following is likely to present in CSF. So they are asking you like what will be the findings. So remember, TB is a bacteria and it's a chronic bacteria, chronic infection. So lymphocytes are ruled out. So you have option of lymphocytes. Now see, I told you bacteria, they love sugar. So they will eat all the sugar from the CSF. So you will see low sugar. So lymphocytosis, low sugar, and proteins will increase in any meningitis. So low protein, that is already ruled out. So remember, proteins and pressure, this will increase in all sort of meningitis. So answer will be lymphocytosis, low sugar, and high protein. And this type of CSF, what we call this as Cobb-Webb CSF. Cobb-Webb CSF. Okay, coming to next, a 60-year-old present with sudden onset right side hemiparesis for last 3 years. BP is 200. All can be done except. So you can see like this CT was given. So you can clearly see a bleed. So it's a case of ICH. So in ICH, what they're asking you, what you will not do. All can be done except. So can we do hyperventilation? Yes, we may. Can we give mannitol? This mannitol will decrease the intracerebral pressure. So that also we can use. BP control also we can do. Thrombolysis absolutely contraindicated because patient is already having bleeding. So it's a case of hemorrhagic stroke. In that case, you will never do thrombolysis. Very, very important. Okay, next one. I can say this was the question. This question came in exam. 51-year-old male with tremors, emotional problem, and cognitive defect. History of trinucleotide repeat disease in father. What is the diagnosis? So there is tremor, emotional problem, and cognitive defect. There is history of trinucleotide repeat. So again, Parkinson will not have that history. So Alzheimer will not have that history. So only 2 diseases which will have history of trinucleotide repeat. That is like there are total 4 diseases. Like we have Huntington disease, we have Friedreich's ataxia, we have Fragile X syndrome, and we have myotonia dystrophy. So these 2 are not given the option. Now we have only these 2, Friedreich's ataxia or Huntington disease. In ataxia, there will be mainly problem with the gait, problem with the ataxia. But patients having tremors, patients having emotional problem, cognitive defect means dementic feature. So that is more towards Huntington disease. So answer for this question will be Huntington chorea. And in Huntington chorea, what you will see CAG repeat. In a patient with dialysis dementia, what is deposited in cerebral cortex? So understand this. In cortex, what you will see, like different type A amyloid. The it is like dialysis. In dialysis, you will see A beta 2M. I think this was the question, and this is the answer for this question. A beta is seen in brain, in CNS, and it is seen in a patient with Alzheimer disease. Transthyretin we see in heart, and it is seen in a patient with restrictive cardiomyopathy, RCMP, or sometimes it is seen in some familial form, like we call this familial amyloidotic polyneuropathy. Is it clear? So again, amyloid beta or A beta is same. So answer will be in dialysis. What you will see A beta 2M. This M stand for microglobulin. Microglobulin. Is it clear? Okay, moving to next antibody in AIDP. So AIDP is like acute inflammatory descending polyneuropathy. That is a variant of GBM. So I told you like Green-Berry syndrome, that is GBS. In GBS, you will see there are two variants. Like we call this acute variant, and we call this chronic variant. So in chronic, what we have CIDP. In acute, what we have AIDP. We have Aman, means acute motor axonal neuropathy. Then we have AMSAN, acute motor sensory axonal neuropathy, and we have Miller-Fisher syndrome. So in AIDP, generally what we see like anti-GM1 antibody, and remember like there is like 2 to, I can say, 2 to 4 weeks period before appearance of the symptoms. So generally, like in that, if you can see like 2 weeks means 14 days, and I can say 4 weeks means it's around 28 days. If you see that much period gap, then antibody will never be acute type antibody. So remember, it's a case of which antibody we can see antibody of IgG class. It will not be IgM, and these two are not same. So antibody, this is like a good question came in exam. Antibody will be IgG type. So basically, name of antibody is anti-GM1, and anti-GM1 is which class of antibody? Anti-GM1 is generally IgG class of antibody. 13-year-old patient with smoky urine or cola color urine, dysmorphic RBC. This is the biggest hint in the MCQ. Dysmorphic RBC means that is clearly suggesting you of glomerulonephritis. And which glomerulonephritis? It's suggesting you of nephritic syndrome. And you can see cola color urine, RBC is more than 20. WBCs are very little. So bladder calculi means bladder stone. So remember, bladder stone will also have hematuria. But first thing, that will not be smoky. Second, there will be no dysmorphic. In calculi, you will see isomorphic RBC. Again, it will not be UTI. Now we have MCD. MCD is having more proteinuria. It is mainly a nephrotic disorder. So answer for this question will be PSGN, post streptococcal glomerulonephritis. Okay, moving to next one. Again, this was a question which was out of the board. I can say this is the only question which came out of my notes. I repeat. But again, if you have slept enough in exam, you can use your brain and still you can make a diagnosis. So remember, it's like a pharmacology medicine overlap MCQ. Elderly male with history of COPD, hypertension, diabetes, or multiple drugs. Which criteria is used to avoid use of certain drugs in old patients? So in geriatric population, they're asking you what is the criteria that we use. So remember, we know Duke's criteria is for infective endocarditis. Light's criteria is for pleural effusion, and we know Jones' criteria is for rheumatic fever. So these three are ruled out. So you don't know the answer. I was not knowing the answer, but answer will be this beer criteria. Trust me, I was not knowing this criteria before this question came. But still, we can make the answer correct because we are knowing other three criteria. Simple. Light is for pleural effusion, Duke's is for infective endocarditis, and rheumatic fever. What we have Jones criteria. Am I clear? Okay, then which drug is least useful in management of patient with thalamic Dejerine syndrome? So understand this. Thalamic Dejerine syndrome. So it is a part of stroke syndrome. We have discussed this. Stroke syndrome. It's the part of stroke syndrome. So when you see it's the part of stroke syndrome, in stroke syndrome, what we can see? You can see like neurology, neuropathic pain. So neuropathic pain. So understand this question. Try to understand this question. Stroke syndrome means there's neuropathic pain. In neuropathic pain, you can use TCA, yes. You can use gabapentin, yes. You can use cannabinoids, yes. there is no role of analgesics. Analgesics are not that effective in a patient with neuropathic pain. That's very, very important. Clear? Okay, moving to next one. Following will help in making diagnosis of bronchial asthma. So remember, in bronchial asthma, how you make a diagnosis, you will see like FEV1. FEV1 will be more than 12% above baseline. Here 15 is given. So that is the best answer. Other option, like some people are saying it was given X-ray. So we do not make any diagnosis based on X-ray. It was CT and something else. So remember, whatever are other option, the diagnosis of bronchial asthma will make when you see like FEV1 is increased by more than 12% above baseline. Okay, then there are a few questions more. So just let me just read this question so that you can get an idea. This is the question number 38. I could not get the time to make this question. So there was a question on Wegener disease. There was a question clinical case. So just I'm writing the clinical case in front of you. It was like a 30-year-old with recurrent episodes of epistaxis. So this was the question. You can see epistaxis, right? Runny nose. Then you can see the patient is having hemoptysis. Hemoptysis was there. Cavitatory lesion. In both lungs. So understand this. You can see it is URTI, it is LRTI, and one more thing is mentioned, hematuria. So URTI, LRTI, hematuria, these are features that we see in a patient with Wegener's granulomatosis. And for Wegener's, the question was asked like, what is the name of antibody? So it was Cianca. So remember, Wegener's, the antibody that we use is Cianca. Coming to next question which came in exam. So this will be question number 39. So understand this. In this question, they have asked you about like what should be the dose in a patient of hyponatremia. So understand this. So this it was given like sodium value is given 120. So normal value of sodium is 135 to 145. So we have to calculate. So this was a female patient with sodium value as 120. So question was we need to calculate the corrected sodium. So how to calculate corrected sodium or corrected amount of IV fluid that we should give? So we should calculate this by a formula that is total body water 140 minus the given value, means 140 is expected, 135 to 145, average is 140, and how much is given? 120. So total body water you should know how to calculate. So remember this is calculated by, you can see like patient weight should be there. So weight was given 40 kg. So total body water, for this we have a formula like weight in kg multiply by 0.5, it's a female, 0.6 it's a male. This is the formula for total body water. So you can see 40 into 0.5 and 140 minus 120. So you can write like this, 40 into 0.5 and this will become into 20. So if you do this multiplication, this will be 200 into 400. This will become around 400. So this was the question came on like correction of sodium or IV fluid that we should give, that is 400 per day, correction per day. Okay, then there was a question on like there is an elderly patient with a case of multiple ring enhancing lesion. Multiple ring enhancing lesion. So this was a question like image based question came in exam, I can say few years before. So it's a case of NCC. The question was all are given in emergency except. So these are the options. So in emergency what we should give? We should give steroid. We should give anti-epileptic drug, AED. Then third option is like we should control edema. And fourth option is what we have, we should give anti-helminthic medication. So understand this question, like it's a case of neurocystic sarcosis. So in steroid we can use. Why steroid? Because this will decrease the inflammation, this will also decrease the edema. Anti-epileptic drugs we can give because this will control the epilepsy, this will control the seizure. We can control edema by giving drugs like mannitol, but anti-helminthic drugs, these are not needed on urgent basis. Is it clear? So this was the question, these are not needed on urgent basis. Is it clear? So this is the answer for this question about NCC. So I can say this was 39 and this was question number 40. So these were 40 questions. Out of these 40 questions, remember all 40 questions came from our notes, except this one, which you can ruled out by by ruling out other choices. So this is from my side about the discussion of medicine. Thank you so much. Keep working hard. Bye bye.